But coming back to this maintenance therapy, now the case that you discussed, Richard, was on maintenance therapy, but with a biologic. But first, let's take it back to first there was Optimox 1 and 2, which was maintenance therapy without a biologic. And Mike, what are your thoughts about maintenance therapy? Do you use a biologic or not? Or what do you use as maintenance therapy for your patients?
Yeah, well, clearly the chemotherapy component, I think we've seen time and time again, is an important part of the maintenance therapy if you're going to use it. And as you pointed out, the Optimox trials tell us that there is utility to continuing a chemotherapy drug. Oxaliplatin obviously is impractical to give long term, and so it's natural that we're going to stop at 6 or 8 doses of it anyway. As far as adding on the biologic, we have data with bevacizumab plus chemotherapy that's showing, consistently there's a progression-free survival benefit, and at least one study, an overall survival benefit, small, but a benefit to adding bevacizumab to the chemotherapy. The reverse is not so clear using just a biologic, and I think we see the same thing here in the Valentino trial, which is really not so much a study of the benefit, yes or no, of maintenance anti-EGFR therapy. It's really, again, is the chemotherapy component important there? And I think it proves once again it is. Because the biologic in general adds only a small amount of additional toxicity, and because my opinion is that a biologic with chemotherapy is a little bit better in terms of at least progression-free survival, I continue to use the biologic if we're going to continue the chemotherapy.
That's a great point. So what about you, Richard? I mean, a biologic with VEGF has its own side effects, but a biologic with anti-EGFR as a maintenance has its own side effects. Like you said, patients can get rash and fatigue, and there could be other issues. So how do you tackle this problem with patients?
I agree with Mike's point of view that in the maintenance therapy, obviously the concept of maintenance therapy came about because of oxaliplatin. Right? We cannot do oxaliplatin forever, so you need to put up some maintenance therapy. There's lack of data of using Bev alone, I think. So Bev alone should not be used, but there's data that you could possibly use a combination with the 5-FU plus Bev. They're clear data, like you said, some PFS benefit, some OS benefit in that setting. So I think if you use bevacizumab as a maintenance therapy, there's data that you could use probably a 5-FU plus a Bev in the setting for a maintenance therapy. However, EGFR maintenance therapy is a question. I just present the Valentino data that really doesn't answer the question of maintenance therapy. It just asks that 5-FU plus panitumumab is better than panitumumab alone in maintenance therapy. The trial to me was a negative study. However, that sort of contradicts to the MACRO-2 study, which was a trial using cetuximab as a maintenance therapy. You may know that the trial was a FOLFOX plus cetuximab, and I don't remember exactly how many cycles. After certain cycles, they were randomized to continuation of FOLFOX cetuximab or cetuximab alone. It was a non-inferiority study, and it met its endpoint. So cetuximab was non-inferior to FOLFOX plus cetuximab. So you have two conflicting data here. With panitumumab, you have to give it 5-FU. Cetuximab, you could probably do cetuximab alone. So I think that's the problem of using sometimes cetuximab as a first-line therapy. Is I don't know what to do with maintenance therapy. So it's still a controversial area. But if you're a purist, I think there's data you could use cetuximab alone as a maintenance therapy. But however, if you use panitumumab first line, obviously from the Valentino study I showed you, you probably have to use 5-FU plus panitumumab because that seems to be better than panitumumab alone.
But the chemotherapy is probably important. I know the cetuximab study showed, but I think most of us in clinical practice do continue with at least a chemotherapy backbone and think about continuing the biologic on top of that.
Right.
This has been a great discussion, so I'll just go, the take-home points out here are that if we go for in asymptomatic patients, probably the current data is that there's really probably not much benefit of doing resection upfront in these patients, obviously based on the clinical outcome of the patient and what their clinical situation is. On the sidedness, left side is anti-EGFR therapy or bevacizumab. On the right side, do not use the anti-EGFR therapy, and that's, I think, very clear. So the right side is more clear than the left side. The left side is we're still trying to figure that out. However, prognostically, the left side, if you have a left-sided tumor, you're going to do much better regardless than if you have a right-sided tumor. Second line is still unclear, but because we don't have enough data, so you could continue with an anti-EGFR therapy in second line or possibly third line in these patients. In the maintenance therapy, probably through the Optimox data, you should continue a chemotherapy backbone. Potentially, you could continue the biologic, which is anti-VEGF therapy to it, or you could do single-agent cetuximab, or do the combination of 5-FU panitumumab. So that's a lot to digest, but I think that was a great discussion. Thank you.